Good afternoon, good morning, ladies and gentlemen. I have nothing to disclose. Today, there are two strategies in the SFA intervention. One is the leave nothing behind strategy, which is based on the standalone DCB treatment. Another one is the leave scaffold behind, which is based on the stent-based treatment. Treatment strategy should be appropriately selected according to the lesion severity. Recently, we have a great hope for stent graft treatment in complex femoral popliteal lesion. Despite extremely complex femoral popliteal lesion, including in this Japanese ID trial, primary patency was 88%, representing comparable result to surgical bypass therapy. Shown here in right side is a 1-year follow-up angiogram. Both lesions did not need reintervention. Follow-up angiogram apparently differ from each device. However, it was reported that frequency of stent thrombosis was the highest in the SF-specific devices. Based on early experience of stent graft treated under IVUS evaluation, the indication for the stent graft implantation is limited in case with low risk for discontinuation depth and with good running zone. This slide shows the 2-year result of the IN.PACT SFA Japan trial. Results show the superiority of the IN.PACT DCB over PTA with significantly higher primary patency in Japanese PAD patient. I think this result is the best among DCB trial. We have a strong confidence of DCB use in our daily practice. Here is a 4-year follow-up angiogram after IN.PACT DCB treatment. 4-year minimum lumen area was larger than just after procedure, representing the positive remodeling was found. Despite drug in tissue remaining approximately for 180 days, treatment effect is sustained through the 4 years. In our DCB practice, for preventing the major dissection and maximizing the therapeutic effect, IVUS play an important role. From this finding, adhesion of the drug itself can be confirmed by IVUS. We call it IN.PACT ring. So in this case, 2 months follow-up angio was performed after IN.PACT DCB treatment, and positive remodeling was already revealed in the early phase angio. Time course of vessel healing after IN.PACT DCB therapy is beyond our expectation. In this case, without vessel calcification, even though the residual stenosis was found just after IN.PACT DCB dilatation, follow-up angio shows a larger lumen expansion was found. Here is a 2-year result of IN.PACT DCB for long femoral popliteal disease. In this study, complex lesion including 25 centimeter lesion length and a 50% frequency of the CTO was studied. 2-year primary patency was 70%, representing the almost comparable to the result to surgical bypass therapy. On the other hand, another 2-year result of DCB in the real-world practice was reported from Leipzig team. 1 and 2-year primary patency were 79% and 53% respectively. If you take a look at the Kaplan-Meier curve, results were linearly decreased. Why are results so different? So when we compare the patient rim and the lesion characteristics, variables which have been well known as a predictor of the loss of patency are very much more frequently observed. We think these predictors attribute to the decreased therapeutic effect of the DCB. Most important thing when we use the DCB in SFA region is to understand which factors are negatively affecting the loss of patency. Here is a very famous paper from Italy. This study suggests that calcium represents the barrier to optimal drug absorption. Circumferential distribution seems to be the most influencing factor with the worst effect. So how about the efficacy of the DCB on the region with eccentric calcification? Time course of a region treated with DCB was similar to that of the region without calcification. From IVUS finding, there's a part of calcification in the SFA lesion. We could see the IN.PACT ring just after DCB dilatation, and 1 month angio revealed that snowman sign was found. Based on this result, we strongly speculate that sufficient effectiveness of the DCB was expected in the case with mild to moderate calcification. On the other hand, in this 1 month follow-up angio, we can see the recoil after DCB treatment. From this 1 month IVAS follow-up, recoil was clearly found. From this image, some prior adjunctive therapy would be needed to overcome this concentric calcification. Here's the IN.PACT global study, stented versus non-stented analysis. 353 patients were treated with provisional stenting. The reason for provisional stenting is shown in this slide. Persistent residual stenosis over 50% was the main cause of the stent implantation. When we take a look at the difference of lesion morphology, it is easily understand which region would be needed a stent implantation. In DCB stented group, lesion length was longer, frequency of CTO and severe calcification was higher, and the diameter stenosis was greater. Based on our clinical practice, DCB alone strategy cannot overcome lesion being easy to recoil. We should draw the line in the lesion with concentric calcification, but we can overcome these regions if treated with DAT or RAT. No line will be present in the DCB treatment if you have a strong motivation. Thank you very much.